Oncology, and it's the first of a series of presentations. And Dr. Williams will give a bit more introduction around horizons in Neuro Oncology shortly. I'm Lily, I'm the clinical research practitioner at Imperial, and today I'm going to be facilitating this session. I'm just going to give you a couple of housekeeping. So we are recording this session so that we can upload it on YouTube for those that can't attend today or others that would like to listen again to the presentation. There will be an opportunity for Q&As at the end of the presentation, but feel free to put in questions in the chat box during the presentation if needed. I will ask you all to keep yourself on mute during the presentation. And when we do go to Q&A, it will be a matter of putting your hands up using the raise button function. And I will pass over, we will ask you to do an evaluation form, which I will share at the end of the presentations on how to do this and how to complete it. I'm going to pass over to Dr. Williams to do a brief introduction around what Horizons in Neuro Oncology is and our vision, and then give us a lovely introduction to and warm welcome to Professor Van Gool.
Thank you very much, Lily. It's lovely to see you all virtually. So as Lily said, this is the first in our session of the Horizons in Neuro Oncology. So Horizons in Neuro Oncology is really an effort to make it a bit easier for everyone, staff, researchers, clinicians, but also patients and carers, to learn about novel and potential and upcoming treatments in brain tumours. So all of us are very familiar with the established standard of care. And if you go to large conferences, you may hear a lot about sort of exciting work done in mice. But we felt that there was a gap about the stuff that might actually be applicable in humans, but isn't yet proven or isn't yet widely available. And that's really what Horizons in Neuro Oncology is designed to fill. So if you look at our webpage, we've got a series of talks outlined. I think there are only 5 outlined so far, but in fact, we've got a program planned until the end of 2024, and I'm already beginning to book 2025, which is really good news. We hold them monthly. They last for an hour. At the first 45 minutes are our introduction and talking, and then we're going to allow 15 minutes for questions at the end. So I'm now going to hand over to Professor Van Gool. So I've known Stefan via email for quite a long time now, because he runs one of the 2 immunotherapy clinics in Germany that I think are the most reputable and the most interesting. And he's done lots of really interesting work around potential immunotherapy approaches, which may be of benefit for patients with GBM. And so I thought it'd be an excellent opportunity to hear him talk about it. Stefan, over.
Yeah, thank you very much for attending my session and for an invitation to have this talk. We are indeed here in Keulen, about 2 kilometers from the big church, the Dome of Keulen. So this is in walking distance in a completely normal building, but with all techniques available to do this individualized multimodal immunotherapy in the combined strategy for the fight against GBM. We have local hyperthermia, whole body hyperthermia is not for brain tumors. We have Newcastle disease virus as oncolytic virus, and we have a full equipped GMP laboratory, good manufacturing practice laboratory, and we have the approval to produce dendritic cell vaccines for human. What you don't like to experience in your life or in the lives of your families and your friends is like this Ukraine lady from 34 years old at the end of her pregnancy, suffering from this huge glioblastoma multiforme, which is in fact also inoperable. And the standard of care after neurosurgery is in fact already defined in 2005 and further elaborated in 2009. And this is the combination after neurosurgery of radiotherapy plus chemotherapy, temozolomide, and then a maintenance phase of temozolomide. And the overall survival data here, you start with 100% of the patients and you follow up them over the time, this is an overall survival curve, then you can see with radiotherapy alone, patients are dying. And if you add the chemotherapy, the death is coming a little bit slower, and not all patients anymore are dying in these curves. And these curves depend on the clinical risk profiles, the recursive partitioning analysis profiles, and with higher risk patients, you have a less good overall survival as compared to lower risk patients. That is in fact what this curve is telling. And in this period already, it was discovered that a molecular profile was really also influencing the overall survival. Here the MGMT promoter methylated patients, they do already better with radiotherapy alone as compared to the MGMT promoter unmethylated patients. And the gain of temozolomid in the MGMT promoter methylated patients was more clear than the gain with the addition of chemotherapy in the blue line for the patients with MGMT promoter unmethylated patients. That was the standard of care. That is the standard of care even today, many years later. So in fact, it's not satisfying. And even in 2015, people have published that the years of potential life lost due to brain cancer is in fact still one of the highest of all cancers that humans can have. So we still have an unmet medical need in spite of 3 pillars of anti-cancer treatment, which are put in a combined strategy. So combined is my first keyword. But it is not enough, and people have tried to do further clinical studies. And one question was, let's make this chemotherapy more dose dense. And they did a randomized phase 3 trial to see whether the overall survival would be improved if you give a dose dense temozolomid schedule. Unfortunately, this trial was negative. Other people have asked if we work on the blood vessels and we make anti-angiogenesis with bevacizumab or Avastin. And again, they designed a randomized clinical trial with bevacizumab. Unfortunately, this trial was negative. And people came out thinking, what are we in fact doing? And we do not gain overall survival, but what about the toxicity? And here a publication in 2022 in the Journal of Clinical Oncology, which is a high-ranked journal in oncology, people are starting to ask if we give intensive treatments, what is the gain in overall survival and what is the cost in clinic days and the loss in home days? In contrast to if we only treat in a minor way at the end, these are theoretical data, of course, then maybe we have less overall survival, but much more time spent with good quality of life at home. And in this trial, they mentioned explicitly the trial with the temozolomid in the unmethylated patients, so the curves that I have shown. The gain in these patients is 27 days. But if you calculate, you have 28 days that you are busy with blood counts and doctor visits. So the toxicity is an issue if the gain of survival is only very moderate. So people have started to ask, let's work more targeted. And a 5th pillar came up. the targeted therapy, and there are in Germany, but surely also in England, a lot of targeted therapies that have been developed over time. But in brain cancer, we have a very particular problem. Brain cancer is a very heterogeneous population of tumor cells and non-tumor cells, which form the tumor microenvironment. And even in this publication in 2023, it is mentioned here a unique...
Sorry, guys. Sorry to interrupt, but just so to be clear, are you showing something? Because I can't see anything. If you are showing a presentation, you need to share your screen.
Yes.
I can see it.
Can you? Or maybe it's just me then.
I can see it.
All right, thank you. Thanks for raising it. Can anyone else not see the pictures? Okay, fine. Ulrich, thank you for raising it.
Sorry.
Ulrich, can I suggest you drop out and rejoin? Because that's probably the easiest way. Stefan, sorry for interrupting, but thank you.
No problem. It's
Please
good.
carry on.
So the problem with the targeted therapies is that the heterogeneity of the tumor make, in fact, these targeted therapies less effective. Here it is even mentioned ineffective. And on top of that, what we also know is that the dynamics of tumor subclones make it really difficult to target one metabolic or signaling pathway in these tumor cells, because the day after the tumor cells are already with other subclones further appearing. So the Neuro Oncology group really knew this problem, and in 2023 there was this review in the Neuro Oncology journal with a potential solution: cell-based therapies for glioblastoma, a promising tool against this tumor heterogeneity. And if you look into their figure, these are all immune cells that now eventually can be used to target this tumor with its heterogeneity characteristics. 2023, but in fact, already 10 years ago in Science, cancer immunotherapy was called the breakthrough of the year. And now the word immunotherapy has been mentioned. And the audience should know that immunotherapy is a very heterogeneous term. It has a lot of different contents. And we have summarized in this publication last year, 2023, that there are indeed several modes of immunotherapy that you can discuss in the context of GBM treatment. So if people speak about immunotherapy, the first question you have to ask is, what do you mean with immunotherapy? They will not mean restorative immunotherapy. That does not work and it is too toxic. But the other immunotherapies are present in clinical application. And some of these immunotherapies are personalized. That means they have something to do with the specific characteristics of the tumor cells. Others are individualized. That means they have something to do with the specific characteristics of the tumor cells, but also with the specific characteristics and the immune identity of the patient. That's the difference between personalized and individualized. And if you combine these modes of immunotherapy, you come up with the word or the term that we have initiated, individualized multimodal immunotherapy. That means there are individualized components in the immunotherapy modes within this complex treatment modality, the IMI, individualized multimodal immunotherapy. Let's review simply the different modes. Passive immunotherapy is personalized. I simply took the Wikipedia to explain. So you have somewhere an antibody that connects to a target on the tumor cell, It can bind an immune cell to the tumor cell. The immune cell can do its job and the tumor cell is gone. And there are even extra modalities. You can connect a radioactive solvent or a chemotherapy to these antibodies, or you can use bispecific antibodies. So a whole world is here possible. But the big problem in GBM is the blood-brain barrier. These antibodies do not simply go through the blood-brain barrier. Adoptive immunotherapy is individualized. So you have also to take into account the identity of the immune system of the body. Wikipedia, how does that go? You take the tumor, you take immune cells out of the tumor, you expand. Or you take blood, you manipulate the blood, you expand, and these expanded immune cells are reinfused. A lot of cell products are meanwhile known, and CAR T cells are maybe the most known at the moment, but there are also CAR NK cells. This is really extremely important, innovative research, and one of the leading clinicians and scientists knows already that he has awarded for this discovery of the CAR T cells the Breakthrough Prize in Life Sciences. But again, in GBM, there are a lot of problems. The tumor heterogeneity, I have already said, the downregulation of the antigens, the very suppressive microenvironment, immune-based toxicities, and so on. So there is evolution here, and we even are doing research and development at the IOZK for making such expanded T-cell products, but this is still a lot to work before it comes into reality. Nevertheless, in our combined anti-cancer strategy, we have these targeted therapies, also targeted immunotherapies, personalized or individualized as potential strategy. So let's move to another one. Immunogenic cell death immunotherapy. Immunogenic cell death is a completely new term in oncology, and the definition has been worked out and have been clarified. I even contributed to this research group, and now we know if we kill tumor cells in a particular way, the immune system becomes alarmed, pick these antigens up, go to the lymph nodes, stimulate the immune cells, and the immune cells learn to fight against the cancer. That is immunogenic cell death immunotherapy. And nowadays, we know that radiotherapy can in fact induce immunogenic cell death. Chemotherapy can induce immunogenic cell death. Electromagnetic waves, tumor treating fields, can work over immunogenic cell death, modulated electrohyperthermia as well, and the whole new world of oncolytic viruses can work over immunogenic cell death. And people have brought this into clinical reality. The tumor treating fields are clinical reality, and they work, as I have said, over immunogenic cell death, besides the tumor cell dividing paresis or paralysis that they induce. So they work over immunogenic cell death as well. And this study on tumor treating fields gave a positive result. So we have now a fifth pillar in the anti-cancer treatment, the immunogenic cell death immunotherapy. And now we are learning that these actions are not only direct anti-cancer actions, but on top of that, you can have already a little bit a treatment-induced anti-cancer immunization, which can be exploited. There are two other modes of immunotherapy, the modulatory and the active-specific immunotherapy, personalized, individualized. Let's go to the modulatory immunotherapy. Again, a lot of techniques are available, checkpoint inhibitors, in-depth anti-inflammation, the bisphosphonates, whole body hyperthermia, but the most important, of course, is the checkpoint inhibitor, for which even in 2018 a Nobel Prize has been given. And it is fabulous. In melanoma, for instance, here you see the results with the chemotherapy, and just coming with these checkpoint inhibitors alone or in combination, look, the overall survival of these patients is extremely improved. So this is really a breakthrough in cancer treatment. And you can do or manipulate the checkpoint inhibitors and use the checkpoint inhibitors at the level of the stimulation. Just to explain how it works, if you have antigens, you stimulate a T cell and a lot of things happen. And at the end, there is a down-regulation signal. So to slow down again this immune reaction. So if you block here, for instance, with ipilimumab, you block this down-regulatory signal and you have an explosive reaction of the immune system, potentially also causing side effects. You can also use checkpoints at the effector arm when a cytotoxic T cell has to kill a target cell. Again, a little bit biology. You can see if there is a negative signal from the target, your cytotoxic T cell is slowed down. If you block this signal, you block the slow downing signal, and your cytotoxic T cell is much more active. So this is really a breakthrough in cancer treatment for several diseases. There are two remarks that might become important in the future. Researchers here, Journal of Clinical Oncology in 2022, are asking, do we need these high doses that are now used, or can lower doses be used? That's a question. But another discovery just published this year is that this PD-L1, which is on the target cell, and for which now patients are selected to get the antibody, yes or no, they do not only play a role at this level, but they also play a role at other cells within the tumor microenvironment. So maybe we are selecting using a readout that is not completely correct, and the biology and further developments might be located in the manipulation of the immune suppressive tumor microenvironment as a whole. That for the modulatory immunotherapy. The last is the active specific immunotherapy, the anti-cancer vaccines. They are individualized. And for each vaccine, there are three elements. What is the antigen? There are several types. What is the carrier? That can be a dendritic cell. And what is the danger signal? That can be several products. For the dendritic cell, and for the importance of the danger signal to stimulate the immune system, the Nobel Prize has been given already in 2011. These vaccines have entered the clinical reality. Here, for instance, with a peptide vaccine against a specific target which can be present on glioblastoma, this study, phase 3 randomized clinical trial, failed. But this study, double-blind, randomized, placebo-controlled phase 2 trial with dendritic cell vaccines using a cocktail of specific peptides as antigens, this study was a success. Linda Liao has published her study as a phase 3 study using tumor lysates in dendritic cells as antigen. I have explained there are several types of antigens. This was a quite difficult study. It was a very big study, but they at the end had to use an external control arm to have the appropriate readout. And this external control arm was in fact the control arm of all these contemporary published randomized clinical trials. So with this, they could end up with a phase 3 trial with this externally controlled arm in a cohort, and the study failed for the MGMT promoter unmethylated patients, while the study was a success for the MGMT promoter methylated patients. So it is a very difficult issue, and I have also been working in this domain for many, many years. And I designed also a trial where the immunotherapy with vaccines was located during the chemotherapy, but I used a control arm where the vaccine was used after all the chemotherapy. And in 2019, I found that, in fact, the overall survival in 2 years had a trend to be better in this arm as compared to this arm. And then the insight came that we have to work in multiple phases. And that is what I want to try to explain. We know the tumor can block the immune system, not only in the tumor microenvironment, but even in the systemic compartment. So what we are doing is surgery, radiochemotherapy, maintenance chemotherapy. We reduce the tumor volume, we reduce, hopefully, also the immune suppression. But we reduce also the immune system under this chemotherapy. And on top of that, we induce potential new clones because we manipulate the genetic structures, and it might be that new clones appear in the context of these alkylating agents and the radiotherapy. And they have a free way forward because our immune system is at the same time reduced. So they are not anymore blocked by any immune system. So that is what we have to take into account. We have to try to kill this tumor cell not only with alkylating chemotherapy and radiotherapy, we can already induce this immunogenic cell, that immunotherapy in this phase, so that we kill also tumor cells and eventually new clones with other modes of action, the oncolytic virus, the modulated electrohyperthermia, and we know we can combine these technologies with temozolomide. So after this first anti-cancer phase, where we use more pillars, this one in combination with these pillars, we have then to do the second phase. So we start thinking in the multi-phase approach. Now the vaccines and the immunomodulation should come. How can that be explained? Here you see the cartoon. We now start active specific immunotherapy and modulatory immunotherapy, and we try to induce the immune system that now can suppress the tumor cells. And dendritic cell vaccines, I have mentioned the study by Wen, and I have mentioned the study by Linda Liao, but there are many meta-analyses that show that dendritic cell vaccines can improve the long-term overall survival in patients with GBM. One particularity that we are using is the antigen. If we come now here with our immunization and with our dendritic cells, we should not only have the antigens of this tumor prior to radiotherapy and chemotherapy, but also the antigens of these new clones. And that is why we have established the technology to yield extracellular microvesicles and apoptotic bodies to have the actualized antigens for loading the dendritic cells. Finally, we are very convinced that the job is not done. we have to introduce a third phase, maintenance and expansion of the immune protection. Why? Because we know that the tumor will try to escape this immune protection, to go to the left or to go to the right. So we have to expand this immune protection, and we can do that with this immunogenic cell, that immunotherapy. We kill the tumor cells, but we induce at the same time an immune response against it. And that is demonstrated for modulated electrohyperthermia, that is demonstrated for the oncolytic virus. At this stage, we can also use particular long peptide vaccines like WT1 and like Survivin, because they are broadly expressed tumor antigens, WT1 even also on tumor-formated vessels, so that also these long peptides help in expansion of the protection of the immune system. And we have meanwhile also introduced a boost DC vaccine, thereby at the end making our immune system stronger with an expanded protection against more tumor cell clones containing more antigens to be covered. That, again, together with the modulatory immunotherapy, checkpoint inhibitors, strong anti-inflammation, eventually stimulation of gamma delta T cells. We also know, meanwhile, that the neurons can stimulate GBM, so we have to work on the neuron glioma axis. We know the particular metabolism of tumor cells, so we can work with a metabolic cocktail. Atorvastatin is also an MACC1 blocker, so it blocks also tumor spreading. And of course, and a lot of people in the UK take melatonin, CBD, THC. This is located at the neuropsychoendocrino immunology axis. This is the schedule that we have developed over many years. And of course, it is important that you report on such schedule that we have done in the beginning of 2023 in this publication. And we speak about real world patients that really come out of the real world. So in this publication, we describe 50 patients coming from 15 countries over the world, the MGMT promoter methylated patients, the MGMT promoter unmethylated patients. They got their diagnosis one after the other, as you can see in both groups. This is the expected overall survival from the literature. These are the overall survivals of our patients, and those patients with the arrow are not yet diseased. And what you can see is that the lines that we have observed are usually a little bit longer than the expected lines that you should observe. And certainly since 2018, we have really these longer living patients in both groups. Now we have expanded these 50 patients with 21 new patients. So now we speak about 71 patients. Again, the expected median overall survival versus the observed median overall survival in the MGMT promoter unmethylated and the MGMT promoter methylated patients. That is what we observe. And of course, we have now to compare these results with this type of treatment with the published randomized clinical trials that I have already discussed. We did that in a new publication also published at the end of 2023. I've said that we have real world patients, so it is important to see whether our patient profile fits to the clinical risk profiles and to the MGMT promoter methylation status as compared in the literature. And here you see the patient characteristics of all these trials, and you see the patient characteristics of the publication, the 50 patients that we have published. And what you can see, maybe our patients are a little bit younger. The sex distribution, you know, females have better prognosis than males, is quite equal. Our patients have less resection as compared to the studies. That is because we have real-world data patients and not selected patients. So that's a prognostic factor which is less good. And also our Karnofsky index is certainly not higher than of the other clinical trials. So also that might be prognostically rather negative. So overall, you can say our patient population fits to the data that have been published. And in our new series of patients, if we look to the 71 patients, in fact, it is the same. These patients' characteristics are quite equal. Here they are again described. And one element which is important to mention, certainly 75% of the patients started their treatment at the IOZK in 0 to 5 months after neurosurgery. So that means usually after the radiochemotherapy during the first or second cycle of the temozolomide. There are some who started later, and in fact, these patients, you can say that's a selection bias, real world patients, but you can say they are here maybe a little bit selected because they are not yet relapsed. But this is only a minority of the patients. Most important, of course, is the overall survival. That is what the people are most interested in. And here you see all the data in summary. The Stuck trial 2005-2009. Radiotherapy alone, the median overall survival in the unmethylated and the methylated patients. Radiotherapy works a little bit better in the methylated patients than the unmethylated patients. That we already know. The addition of temozolomide, here you gain in median 27 days median overall survival, but the 2-year percentage overall survival is a little bit better. It all is better in the MGMT promoter methylated patients. Stuck has used this experimental arm as the control arm in his new trial in 2017 for the tumor treating fields. And as you can see, it is even here a little bit better. That is likely due to rescue treatments. But here in the MGMT promoter methylated patients, the control arm here is not better than the experimental arm here. And Linda Liao have, of course, also used all these control arms of all these trials as control, external control in her study. And as you can see, these are the median overall survivals and 2-year percentage overall survival. So I think also this is in fact the current prognosis of the MGMT promoter unmethylated and methylated patients. As I have already said, the addition of tumor treating fields, so freezing the tumor cells and induction of immunogenic cell death, this was a positive trial. The median overall survival improved in both molecular subgroups, and the 2-year overall survival improved in both molecular subgroups. I've also explained that the Linda Liao trial was negative in the MGMT unmethylated patients, so there is no difference, but there is a major difference in the MGMT promoter methylated patients, as you can see here, also in the 2-year overall survival. If we see now our real-world data patients, eventually with this little bias in some patients, but whatsoever, then you can see that there is a major jump in the median overall survival in both molecular subgroups compared to what you can consider as the expected overall survival with the standard of care. And we see that the 2-year overall survival is almost doubled. Also here in the MGMT promoter methylated patients, it's almost doubled. If we now see in our expanded cohort, so with 21 extra patients, the data are completely confirmed and compared to what you can consider as standard, the 2-year percentage overall survival is again almost doubled. But of course, critical scientists ask, what is the evidence if you use real-world data? Well, the answer of some patients are, it is evident. This is the lady that I have mentioned in the beginning. 2.5 years later, this is the result. So for this patient, it was quite evident that it worked. But for the clinical scientists, you need something more. We need so-called randomized controlled trials. Randomized controlled trials is in fact a concept that has been developed by a British statistician in 1948, so more than 75 years ago. But still today, it is considered as the only way to reach a level 1 clinical evidence of efficacy. And that is the problem where I am now at the moment struggling. Because if we consider what we know these tumors are changing over time with subclones. This tumor faster than this tumor. We know that our patients are different. And in the protocols, we block the steering wheel. So I think if these cars are driving and even they are changing over time with their immune system, I've explained that we block the immune system due to the radiotherapy and the chemotherapy. This is not an honest race, and in fact, all these cars, early or late, will crash. That is what we see till from 2005 years till now. So most of the classical trials have failed because the question is, should we treat highly dynamic tumors in highly dynamic microenvironments with fixed treatment protocols? And I think this is really a problem that we have, because I think it's better to drive in this way. So we need for the future really repetitive, complete evaluations where we have not only the imaging, but where maybe liquid biopsies can help us to see in time that the tumor is changing, that the tumor microenvironment is changing, that the immune system is changing. And that is what I have written in this publication in 2001. So the classical way to look to the clinical evidence in such a complex situation with classical randomized clinical trials, that idea should maybe be challenged. This publication was supported with 2 further publications. And whatsoever, what we also see at the moment, if we have these data published, and they are published, then the question for the patient, of course, is who wants to be randomized with blind placebo control if that might be the difference? So we have to try to apply evidence-based medicine also to individualized medicine. And if we then look back to what has been published in the British Medical Journal in 2014, here you see BMG 2014, by the team who is working in the evidence-based medicine, then they already say you should work with real evidence-based medicine and you should individualize for the patient. You should use judgments and not a priori rules. You should align with the patient care and you should include a public health dimension. So in our work, we have indeed already included the cost effectiveness analysis, quality of life, health utility index, quality adjusted life years. disability adjusted life years. So having these difficulties that we have a little bit to work in another way to try to induce in the scientific community the evidence that this is the way to go forward. But concrete for the patients.
Stefaan, we need to wrap up.
Yes,
so this is this is your 1 minute warning.
I am at my last slide, which might be important for the patients. So standard of care, neurosurgery, radiochemotherapy, maintenance, chemotherapy. Eventually, one can contact us already at this stage somewhere if the wish is to include multimodal immunotherapy. And in fact, some days after the first cycle of maintenance chemotherapy, we can do here the immune diagnostic procedures and the first 5-day immunogenic cell death immunotherapy. And that, of course, in good collaboration, as you know, Matt Williams, with the treating physician in the UK. Important is that the patient has to have a Karnofsky index that is satisfying and that traveling to Köln and staying in Köln is safe and feasible. Related to costs, because that's also a question of a lot of patients. We work in a private non-profit setting and the costs are fixed by the German law. We have to calculate the costs on the concrete medical activities, which are depending on the concrete treatment plan that should be designed and that the patient should, of course, consent to, and payments are stepwise. I think that's also important information for patients. And that's in fact my concluding slide. 3 words to keep in mind: individualized multimodal immunotherapy, a multi-phase strategy, and in each phase use a combined treatment strategy. And we hope that with real-world data that we deliver, that we can contribute to the scientific and the clinical situation for helping these patients, at least to control their glioblastoma multiforme. That's my last slide.
Thank you so much, Professor van Gool. That was very, very insightful and interesting, and you did a very engaging presentation, so thank you. I think I'm saying thank you for everyone that's attended. So can we open up to a bit of Q&A? So if you want, just raise your hand and I will come to you, put a question in the chat, and I will try and alternate between the two. So 1 or 2 from raising your hand and 1 in the chat. So over to you, Claire. Would you like to ask your question? So if you unmute yourself.
Hi, I was just wondering about patients with recurrence like myself, because I've been stable for about a year and then I've had recurrence, and I wish I'd started sooner along this path, but I just want to know if there's, how much, what you can say, if you can give me any hope, basically.
Well, for recurrent patients, I always say we start with a blanco page. So we have really to run through all possible treatments. Is neurosurgery possible? Is new radiotherapy possible? Is new chemotherapy possible? And then this is decided principally by the local oncologist. We can help in discussing, but we let this decision to the local neuro-oncologist, and then we see, based on the standard of care for this relapse situation, how we can plug in again with these immunotherapy modalities, and we can communicate to the patient, but also to the treating physician, which combined approaches can again be used. And so also for relapsed patients that were also in 2001 to 2005, so I'm already very long busy with these, that were all relapsed patients. And in fact, the first patient was a relapsed patient and is still alive. So we are more than 20 years later. So also for these patients, the hope is less strong, but is not nothing. And we can try to help again with a second line plan to get it at maximum and to prolong with good quality of life the life.
Okay, thank
Thank
you.
you. I hope that answers your question, Claire. Does anyone else have any questions? So we seem to have a question from Jennifer Greengrass in the chat. So, how do immunotherapy vaccines and checkpoint inhibitors pass the blood-brain barrier? That's question one. Then,
Yes.
can you combine NK cell infusions with treatments offered at IOZK, and should there be a time gap? And
So-
it sounds like immunotherapy relies on having a good working immune system, which suggests that chemotherapy may not be our friend when we pursue this track. Thank you very much for your talk. So, 3 questions. Do you want me to go back into bit by bit?
So if I can keep, so the first question on the blood-brain barrier. So in fact, the dendritic cell vaccine has not to go through the blood-brain barrier. The dendritic cell vaccine goes to the lymph nodes. There in the lymph nodes, they stimulate the immune cells, and the immune cells have to go through the blood-brain barrier. And then the brain was considered as an immune-privileged milieu. But now there's a lot of research how the immune system still can have its effect in the brain. Also, we know that if there is contrast enhancement, the blood-brain barrier is principally broken. So the blood-brain barrier is certainly somewhere to be considered in a different way. Related to NK cells, we do not work with NK cells. In fact, autologous NK cells in general have not given their promise. Maybe CAR NK cells, that's something different, but that I don't know. Allogeneic NK cells might have somewhere an impact, but that is in our setting here impossible. So we do not focus here at the IOZK on NK cells. And I missed the third question.
The third element of the question was around chemotherapy and your immune system. Therefore, does that have an effect?
So the chemotherapy and the immune system, chemotherapy in generally reduces the potency of the immune system, but chemotherapy does not reduce the potency of oncolytic viruses and of modulated electrohyperthermia, which also kill tumor cells, but at the same time start changing the tumor microenvironment. So therefore, we combine this immunogenic cell, that immunotherapy with the chemotherapy to have a stronger tumor control, but also to change the system so that in the second phase with the immunization, the accessibility of the immune cells is already improved. So chemotherapy can be combined with immunogenic cell-death immunotherapy. We do not recommend combination of chemotherapy with active specific immunotherapy with vaccines. I think we have enough data that is in fact not the good combination to go.
Brilliant. Thank you so much for that answer. And I think I'll leave the final question for Richard to come in. If you want to unmute yourself.
Thank you, Lily. Professor van Gool, that was incredibly interesting, very stimulating. It pulled together all sorts of things that I, as a non-medical person, began to see during the 2 years plus of my wife's illness and ultimately her death 2 years ago. The question I have is, in this country, we have a real problem opening up the possibility for considering combined therapies. The standard of care is the standard of care, and with some notable exceptions, and I here point to Matt, who was fantastic when my wife was ill, but with some notable exceptions, basically, standard of care is what is offered under the health service, and there is not enough being done to look at alternative treatments. Your point about randomized clinical trials is extremely interesting, because it seems to me that is one of the biggest blocks to opening up consideration of alternative approaches, because it's almost assumed that a randomized controlled trial is the only thing that is justifiable in convincing a new approach to treatment. What do you think can be done to try and get the wider medical community to understand that with the heterogeneity of these tumors in particular, that the randomized control trial is not the ultimate test of potential effectiveness?
Well, this is exactly the point, and I would say there are, for me at the moment, two strategies. First of all, gain experience by people who really know the field, who can explain. You have seen each slide had a lot of publications that support the rationale behind. But so there are some pioneers who are exploring these combinations on a rather individualized basis, and we should be very open with the clinical scientists to discuss this data. I have also committed. There are maybe some biases, but at the end for the patient, if he lives longer with the bias or without the bias, that's not the point for the patient. On the other hand, as a group of clinical scientists, we should discuss these issues and we should define new modes of evidences or accept new modes of evidences that cannot anymore neglected. And that is, of course, a role for the clinical scientists more than for industry, for instance, because they have other issues to do. It's a very complicated thing, and I have mentioned it in this way because I myself feel that we are somewhere blocked. We have so much potency. Also, all these diagnostics in liquid biopsy, we can follow these tumors. We can see like all the measuring things in a car. You can measure everything, but we neglect everything at the moment because we are in this dogma of this protocol medicine that should remain fixed while your tumor is going to the left or to the right. And so there, I have also no solution, but somewhere the method of defining evidence should be adapted. And that's why I have mentioned even the note in the British Medical Journal in 2014 by the people of evidence-based medicine. In their recommendation, they say you should work individualized. That's not group, that's individualized. And I think that's an open communication that the clinical scientists at the universities have to face. They cannot neglect it. They have to face it. And we have to come to an innovative solution. The randomized clinical trial concept is from 1948. We are 75 years later. We have so much more knowledge, but we do not take this into account in this strategy. And I think there, a global responsibility of everybody is mandatory. And meanwhile, centers like we have to explore, have to pioneer, have to analyze, and have to communicate. That's my job, so to say.
Right. We are at 6 o'clock, which is
Yes.
perfect timing. So thank you very much for a very stimulating and very informative talk. I think it is important to say that I don't agree with everything that Stefan said, and there isn't time to go into it now, but I think it is possible to design high quality trials of adaptive treatment. And those trials are necessary because in a publicly funded healthcare system, we have to justify why we are spending public money on treatment. And that fundamentally is the need. But anyway, I wanted to say thank you again to Stefaan van Gool for his talk, and also actually for keeping absolutely perfectly to time. So we finished absolutely at 6 o'clock, which is great. I want to say thank you to Lily, who's done most of the organizational work. As you can see, the slide is up. Please give some feedback. So this is the first of our HIN talks. Our next one is in a month's time. So if we need to change things, we have a little bit of scope to change stuff. And thank you all for coming and for your questions and interest. And hopefully we will see you in a month's time. Thank you all very much.
Thank you once again, Professor.
Bye-bye.
For joining.
Bye-bye.
Hello, darling. Hi. Yeah, not too bad. How are you?